So good evening, ladies and gentlemen. Again, thank you for being here with us. Today we're reporting to you that that we diagnosed an additional 424 cases of COVID-19, bringing the total to 4,273. I'm also reporting that an additional 22 people have lost their lives as a result of COVID-19, bringing the number that have died as a result since the beginning of this epidemic to 120. And again, I'd like to take the opportunity to express on all of our behalves our condolences to the families and to the friends of each of those individuals. In relation to those individual deaths, 11 of them were males and 11 of them were females. 18 of them occurred in the east, 3 in the south and 1 in the west of the country. In terms of a breakdown of the 120 in total that we have seen who have sadly lost their lives, the median age among those is 82. 93 or 78% of them occurred in a hospital environment. 15 were associated with admission to intensive care. That was 13%. And 96 reported an underlying health condition. In relation to ICU, a breakdown of 156 admissions to ICU. 115 of those were male, 41 female. The median age of intensive care admissions was 63. 110 of that 156 remain in intensive care, with 31 having been discharged and a total of 15 people who have died following admission to intensive care. A more detailed breakdown of the cases to midnight on Wednesday night, 3,655 at that point, shows 171 clusters of infection, accounting for 626 cases between them, and a median age of 48 years. With roughly a 50-50 split males and females across all of those cases. 28% of them, or 1,039, were hospitalised and 4% were admitted to intensive care units. 26%, now a total of 948, are healthcare workers, and 57% of them, or 2,077, are from the Dublin region. So we're happy to take any questions that you might have now at this point. Aisling.
Doctor, can you just give us a bit more information, I suppose, about the range of measures in the nursing homes? You say you're very concerned about the clusters in these nursing homes and what you've discussed with the HSE in relation to that.
So we had a meeting of our National Public Health Emergency Team this morning. That was again on our agenda as it was on Tuesday. We communicated with the HSE after that meeting on Tuesday. We've continued to engage with them in recent days around the various different measures that will be taken and will need to be taken on a consistent basis. We have seen an increase in the number of nursing homes, particularly in the east. The majority of nursing homes that are reporting this infection are in the east of the country, which matches the pattern of this infection overall, both in the community and in hospital settings, as well as in nursing and residential centres. So a range of measures that are about strengthening the infection prevention and control arrangements, strengthening the training arrangements in relation to those, ensuring that there is an effective public health response in relation to each one of those. That's about identifying the risks in those individual nursing homes and helping to mitigate those individual risks. The circumstances in each individual nursing home that reports these infection may vary, and so the specific measures that have to be taken requires an assessment of each individual one on its own merits. And a range of other measures that we'd like to be able to do to further support staff, both in terms of training and other requirements staff may have. I might ask Dr. Henry, who's able to give you some detail in relation to some of the measures that have already been taken by the HSE this week.
Yes, the HSE is contacting each nursing home, and that's happening as I speak. Also, in terms of the training that Tony alludes to, our Professor Martin Cormacan, our head of AMRIC, Disinfection Control nationwide, he has visited a nursing home yesterday to ascertain the kind of training requirements and infection control that is required, and he held what's called a webinar today. There were over 1,200 people on this, so that's going to inform how we engage with nursing homes in terms of promoting infection control, in terms of advising the staff there on how to limit transmission of this virus, and in terms, of course, of education and training on the use of PPE.
Obviously, the issue of PPE and the quality of the PPE coming into the country has been widely discussed today. Are you happy that what's coming into the country is of a sufficient standard?
Well, first of all, the demand for PPE is well beyond anything we've ever experienced, not just in Ireland but worldwide, and we see some countries running short now or completely depleted of elements of PPE. on one level, we're absolutely we're relieved that we've secured a supply that is multiple of years of our normal supply, even in a few months. And that's coming through from China in 60 flights over the coming days to weeks. And as it lands, again, Professor Cormack and his team are inspecting all elements of the PPE. The PPE isn't one homogeneous group of equipment. There are different elements, and he's breaking it down into equipment that can be used as classified, to equipment that needs to be recategorised. That is to say, for example, a respiratory mask would be more appropriately categorised as a surgical mask. And thirdly, for some elements that are just not appropriate for use in our healthcare system. And we're going back to the suppliers, feeding this back to them and making sure that any future supplies we get from this or other sources comply to what our healthcare workers need, and what will protect them, protect their patients, and reduce dissemination of the virus, which is the purpose of the PPE.
Hi Tony, Conal Thomas from the Journal.ie. I just have a series of questions in relation to testing. Just firstly, can you tell me how many test centres are operational at the moment each day, and for how long? Sorry,
the exact number, I know it's somewhere in the late 40s at this stage. We did at the beginning of this week, as people know, we had to halt testing in some sites because we ran out of swabbing equipment. Again, in a worldwide shortage of this equipment, we managed to secure that. We now have a continued, hopefully, secure supply. So that as our testing centres are not completely back up and running, but most of them are back up and running now. And based on the figures we're getting and the demand we're getting through since the case definition change, it's clear that our testing centres are able to accommodate that demand.
And just on the demand itself, what is the demand like at the moment? And can you give us a sense of whether it's, say, localised in certain areas or not?
Well, it's clear since the case definition was changed, and the purpose to go back, and it's important to remind all of ourselves why that was changed, is to bring greater focus to the case definition and to direct this resource and testing at a tighter group of people that we needed to focus on for the purpose for which testing is, and that is to instigate and trigger contact tracing and all those public health measures which will halt transmission of the virus. So it's clear that since the case definition was changed, there's a much tighter group of people being referred through HealthLink, that's the GP electronic link, through to the centres and also in the testing centres. So it has fallen considerably from the peak that was there before the case definition was tightened up.
You gave us the figures for testing, I think it was Monday or Tuesday, for around just over 30,000. Do you have the figure for today? And will you be providing regular updates, considering more and more testing will be carried out?
We will be providing regular updates each week, and that number has increased significantly since the beginning of this week. We'll give you a new figure on Tuesday evening as of Monday evening's close.
So you don't have it at the moment, no?
I have a figure, but I'm not going to give it out now. It's a significantly increased figure from the 30,000 that we gave you at the beginning of the week.
Can you give us a sense?
It's a significantly increased number.
Thanks, Tony.
Tony, obviously people look for leadership during these times, and there are people on the front line in the healthcare service who feel very let down by the quality of the public or the protective equipment. And I'm just wondering, as a leader, what would you say to them, given that they have to adjust to a quality of personal protective equipment that many of them feel a bit let down by?
George, I could absolutely. It's absolutely core to what we do to protect our healthcare workers in what can be a hazardous scenario of dealing with a virus that's new and against which none of us have any immunity. So in ordinary times, we prefer to have the PPE designed to the exact specifications that our healthcare workers need and that we're used to. It's clear that in a worldwide deficit, with again some countries running out, our priority is to secure as much stock as we can. But on arrival in this country, as I said earlier, our own AMRIC team are looking at every single aspect of that PPE to see what is fit for use in our hospitals or recategorisation or to be sent back. And just to assure anybody who's worried, we are have secured other lines of stock that will be coming through in the coming days, particularly, and we've also stepped up production of surgical masks within our own country. IREMA, which is based in Limerick, is now doubled or trebled production. So we're pursuing different lines of supplies. We're also looking at production within our country. Of course, we'd prefer to be in a different position, to be getting the exact specifications that people would want, if you like, in peacetime. But this isn't peacetime. There's a worldwide shortage. In some cases, countries have run out, and we want to get as much stock as we can get in and deliver the right stock to the right people to be used in the right situation.
Do you think some of the material which came in could be made work if it were amended or if it were modified or anything? Is that something that you think you might be looking at? This is a lot of money, a lot of equipment, awful waste.
It is. I think if there are any amendments to be made, the most useful one we can make is to recategorize it so that people are fully aware of what they're using and what the most appropriate situation of use of that piece of equipment is, be it a mask or a gown or otherwise. So rather than remanufacture what has already been manufactured, we're looking at looking what's coming in. And remember, we've only had a few plane loads in, and there's 60 in total. But surveying it as it comes in, and then specifying and advising what situation is appropriate for in what circumstances.
Okay. Tony, when you were going through the numbers there, you mentioned intensive care units. Is it a lower number in intensive care tonight, or is it an extra number in intensive care? Was it 109 were actually in intensive care yesterday, I think, was when we got the analysis. Is it more this evening or less this evening?
So the figure that I've given you there is a breakdown of a more detailed analysis of cases that isn't right up to this evening.
Right.
So I can't tell you at this moment in time I'm not going to tell you this at this moment in time what the precise figure is, but as of that analysis which was done this morning, the number remaining in ICU at the time of that analysis was 110. And don't forget, there are people now leaving intensive care units as well as going into intensive care units. For the early days, if you like, or for the first number of weeks that we reported intensive care admissions to you, we saw the cumulative number increase day on day because we didn't get to the point, if you like, of a significant numbers of people being discharged from intensive care units. But we now, as I've reported to you there, among those figures, we've seen 31 discharges from intensive care. We've also sadly seen 15 deaths out of the 156 that I mentioned to you.
Okay. I know it's probably a difficult question for you to answer, but I've heard medical people and so on talk about the surge that's coming. And I'm just wondering, because we have been quite successful when one looks at, as you have outlined yourself, in terms of the number of contacts that people have had and the opportunity for spreading the disease has clearly been reduced by all of people's actions. And you look at what is described as the curve. How close do you think we are to this surge? Because people are probably wondering how quick it could come. Is it 2 weeks away, as some people say? Is it possible to say anything like that? Or is that the kind of stuff we just have to keep our fingers crossed about?
So I don't want to be evasive in the answer that I give, George. We don't know. And the reason that we don't know is because we don't know how successful we're going to be in continuing to reduce the rate of growth of this epidemic. I told you yesterday that we think it's growing at the rate now of about 10%. At the beginning of this, it was growing at the exponential rate, or 33%, a so-called unmitigated growth. As we implemented the various sets of measures over the last number of weeks, as the Irish public have worked with us in adhering to those measures, we have reduced the growth of that infection significantly from 33% to 10%. But if we continue to grow at 10%, we will end up with a significant challenge for our healthcare system. The more we can reduce that rate of growth, the less the challenge will be for the healthcare system, and the further into the future that point will become. So if you think of it in terms of a wave, if it continues to grow at a lower rate, the lower it grows, the lower the overall peak will be, and the further into the future that peak will be as well. And so we think the next 7 days or 7 to 10 days are going to be crucial to us in understanding that. We have identified the 12th of April as the date for the most recent set of measures that have been put into place. And we think as we come towards the end of next week, we'll be in a good position to assess what we think the impact of these measures has been and what the rate of growth is at that point. And it should allow us to make much more certain estimates of exactly the question that you're asking me now. So I'm not trying to avoid the question, but it really is a case of the better we do, the lower the peak will be, the further into the future it will be.
Okay. And Colm, could I just ask you one other question? Well, there's probably two. In terms of, since we changed the criteria for testing to 2 symptoms and then the priorities, typically on a daily basis, how many do you think the GPs are putting forward for testing? Would it be between 2,000 and 3,000? Would it be more? Would it be less?
Well, I'm going to a direct figure because it's relatively early days and we're seeing a drop-off day by day. But it's of that order. But I can say it to you, George, is that it's at a measure, it's at a level that our testing centres can manage. And our testing centres have yet to ramp up to higher figures, because we're aiming for further testing once we get all these different elements along the testing pathway completely aligned. We've come, I can appreciate people's frustration, but we've come a long way in a short time with the establishment of these testing centres, with the securing the swabbing equipment, and with the establishment of labs. We started with the NVRL, and now we have 13 or so hospital labs and additional labs coming on board too.
Okay. And the other thing is, we know from Paul Reid and others at the HSE that tests were sent, or swabs for analysis, to Germany, starting a couple of days ago. A significant number of thousands of swabs. Are any of them back yet? And secondly, obviously, have we any idea how many will go? And I suppose as well, it will result, no doubt, in an increase, significant increase in the coming days in the recorded cases, because a lot of tests are going to come through.
Well, yes, we're to ensure continuity, and again to remind everybody the purpose of the testing is to trigger the contact tracing. So we're ensuring that that pathway, that flow continues, and that's the reason for using that particular element of testing in Germany. But those tests they haven't begun to come back yet. But I expect they're going to begin to come back from tomorrow evening onwards. But again, to re-emphasise, I'm sorry if I sound like a record player here, is the purpose of this is to trigger contact tracing. And we did make a decision last week that while waiting testing, we wouldn't wait for these priority groups to undergo contact tracing. And that's something we're going directly to do, because the purpose of the testing is to trigger the contact tracing to instigate the measures that will restrict the transmission of the virus.
Okay, thank you.
Hi, Tony. Mark Tighe from the Sunday Times. Maybe yourself or Breda can answer this. Just in terms of March, you were telling us about cases coming in from northern Italy. There's been a lot of reports today in the UK about a couple of dozen cases being linked with Cheltenham. Can you tell us, is there any significant number of cases or clusters that you've identified linked with the Cheltenham races?
We haven't identified that. It hasn't been reported here.
Okay. And in terms of contact tracing, Colm, you're talking about this, or maybe Tony, in terms of the app that's being developed, can you give us some information about what sort of approach you guys would like to see taken with that in terms of technology? Will it be the Bluetooth technology, handshake, and what do you see being the overall aim of that app, and in terms of helping with contact tracing?
So contact tracing is a process that involves a direct engagement and interview with usually a public health doctor on a case, and then follow up with individual contacts that are identified. That will still be the process that has to exist, even if we have others being brought into it and trained to take the role that public health doctors would normally carry out on the basis of the scale that we are doing as part of this exercise, way beyond the level of contact tracing that would normally happen across all the infectious diseases that happen in the population. There are attempts to try and develop an app to help not just with contact tracing, but to help with a variety of other things, including raising awareness of symptoms and things of that nature, giving people a means of reporting symptoms. We've had great engagement from a variety of different, both technology companies and information companies, offering help, offering assistance in the development of innovative ways of doing things that are far beyond my comprehension. And I think we want to see if we can exploit as much of that as possible to help us. And whether it'll make a prediction that it will help in the contact tracing and replace, I couldn't say that at this point in time. But the intention is to try to develop, in as much as we can, technologies that assist, augment, further inform, further develop, help us to analyse better the various different measures that we're taking. And this app will be no different. And so there's ongoing work in relation to that, and as to whether it can, if you like, assist the contact tracing process and replace what's already happening. That's not our expectation at this point in time. It will still be, as we say, a shoe leather epidemiology exercise to try to identify the cases and the contacts, and to give ourselves the assurance that we're as thorough as we can be. And I say that particularly, Mark, because as we move through the measures that are in place across society, and not making any prediction about where we'll be in terms of the relaxing of those, if we find ourselves in a situation where the behaviour of this disease in the population has improved to the point that we think we might be able to lift some of those challenging restrictions that are in place for society, we have to be certain that our case detection, our contact tracing, our testing capacity is as robust as it can be. so that we can find any cases that occur after that point of relaxation.
Is that where you see the app coming in, maybe possibly
technology-
to help in the relaxation or policing, helping people to police them?
If technology can help us
themselves?
with that, in whatever form it comes, then we'll find that very welcome.
You don't have a timetable at this stage of when that app
So-
might be ready?
So the timetable for that will all depend on the assessment of the disease. So as I was saying, towards the end of
Just in terms of the rollout of the app, sorry.
No, I'm not giving you a specific time in relation to that, no.
But with regard to contact tracing teams, there is a huge effort in training up the contact tracing teams throughout the country, and this is an intersectoral approach. So we have teams being trained up from the army, teams being trained up in colleges, in all different settings throughout our society that are helping, that are volunteering to help out with contact tracing, and this training is ongoing, and it is really the primary focus of the contact tracing initiative. And if the app does come on stream and if it is of benefit, it will enhance that fundamental contact tracing approach.
Can you tell us how many people you expect to be working in contact tracing, say, in 2 weeks' time, Breda?
Well, it's incremental. So the training currently, there's up to 1,400 people trained, and that hopes to be ramped up to much bigger figures into the future. I couldn't give you a definite figure.
How many are in training at the moment, do you know?
Well, I just know the number that are currently trained, and they're being trained on exactly all the different elements of the contact tracing.
1,400 people in training?
No, currently
they're
trained.
trained,
yeah.
Yes.
And there's more in training?
Yes, in training, exactly.
Okay, thanks.
Thanks, Mark.
Paul Cullen, the Irish Times. Good evening. Colin, could I just ask you have you any detail on this consignment from China? What proportion, either by volume or value, is unusable, and what proportion can be repurposed?
Well, we're dealing with the first consignments that have arrived, Paul, so I can't extrapolate beyond that because they're coming from different manufacturers. So, I can't tell you absolute terms in numbers, but I can tell you in terms of categories that some of the masks that were categorised as respiratory masks are more usefully recategorised as surgical masks. But we've doubled up, as I said, our production internally in Ireland of respiratory masks. Some of the elements that we would have expected long sleeve gowns are more akin to bodysuits. So there's a recategorisation involved, that item by item, that I'm familiar with, and has been communicated through to our medical and nursing staff through the hospitals by Professor Cormack, but I don't have numbers in those now.
It's just that if there were only problems with a tiny proportion of a very large consignment, I wouldn't want people to get the wrong end of the stick.
Absolutely. I really don't have a number, but I have a categorisation of it, and just it's important to remember we're dealing with the initial flights coming in, and there's 60 in total, and other supply lines coming through too.
And Tony, you've spoken before this about not getting everything right in terms of a fast-moving emergency, and that's understandable. And I can recall from the early days of these briefings, questions being raised about nursing homes and questions about guidelines, and perhaps I think about PPE as well. Would you accept that we should have focused on that sector earlier and drawn up specifics in terms of guidelines and so on? That maybe our focus was too much on, or I won't say too much, but it was understandably on the acute sector. But, where fatalities are going to occur disproportionately in nursing homes, and perhaps maybe we should have given it more notice at an earlier stage.
So there were extensive arrangements in place across the nursing home sector, preparedness plans in place.
No guidelines.
And infection prevention and control guidelines for healthcare settings that should have been applied in relation to those kinds of environments as well. And as we moved into the epidemic and began to identify the locations in which infection were occurring, we took action then to focus on those residential settings that we were beginning to see clusters in, and raised our level of concern around that as part of the measures. But that's not to say that measures were not either in place or being followed. There is, in reality, across the nursing home sector, no more than any other part of the health sector, a wide variation of both the environment standards, as we know from the work of our colleagues in the Health Information and Quality Authority, and the extent to which infection prevention control arrangements are in place. And it is true to say there are some environments that are very high standard in relation to those, and have been and continue to be very safe and effective places for people to receive nursing and ongoing care. And there are other places that maybe not quite at that same standard. So we have to try to do is to raise the performance of the whole of that sector. But our stepping up of this has to be in response to what we've seen in terms of the numbers of clusters of infection that have occurred in those settings. And we've seen an increase in that even since we've begun to raise awareness and concern about that in the last week or so we've seen over the course of this week. And so that's the basis of our continuing focus on what we're saying and our continuing focus on this at the National Public Health Emergency Team. As we move through, and without saying and predicting that we're as far as we want to be in terms of widespread community transmission, our first focus is to try and reduce the transmission, break the so-called chains of transmission of this infection in the community. And as we've all of the public health measures that are in place now across society, we think and we hope will enable us to do that as well as we possibly can do as a society and as a system, that we now need to move our focus to those institutional settings which characteristically, if you like, in terms of these kinds of viral infections like flu, become locations in which transmission tends to happen at a greater rate than in the population generally, because A, of the vulnerability, and B, because of the environment in which people find themselves, making it easier for that infection to spread. So we have to focus on those locations now.
Colin, quickly, just on PPE again, do you know anything about a joint order with the North for PPE?
No, I'm not sure.
The Prime Minister last week announced that there was going to be a joint order, but I haven't been able to find anything this side of the border about it.
Not familiar, Paul. The procurement is very rapid. Is proceeding at a very rapid pace, so just because I don't know doesn't mean it's not happening, but I'm not familiar, no.
I mean, I have ongoing, and as you know, I've said it before, daily, effectively, with engagement with my counterpart in Northern Ireland, and he hasn't identified a particular need that we would help with there. We'd certainly be willing to work with each other on any issue that we could help each other with, and that's what we do.
Just two quick nerdy queries. Just, I wonder, could you provide us with the mean age of deaths as well as opposed to the median?
We can calculate it. I don't have it right at this moment. Mean and median, yeah.
And just finally, I'm a little bit unclear on the difference between community transmission and local transmission. Maybe you might just put it in layman's.
So we're identifying, we're using the term community transmission in this context to mean a situation whereby we cannot explain how an individual who has been diagnosed with this infection picked up that infection. So they could have picked up the infection by way of contact with a known case, and that might be with a healthcare worker or in a healthcare environment, or it could be in a family setting or something where there's a known case. It could be as a result of travel. But if we can't find any of those explanations, we call that a community transmission. It will be the case then that people pick up the infection here in this country, but from another known case, and we call it a local transmission. So in effect, we're saying, look, the community transmission is that group of people for whom we cannot identify a source of infection for them. They've picked it up somewhere in the course of the previous number of days, the incubation period. We can't explain how they've got it. That's what we mean.
Stephen Murphy from Newstalk. Just on testing, we know healthcare workers, it's obviously one of the groups you've been focusing on. Can you tell us how many healthcare workers have been tested so far?
I don't have that information, but I think one of the important points to get across in relation to this, and we've said this, although a quarter of the cases so far are associated with healthcare workers, there are a variety of reasons for that. One of them is that obviously healthcare workers are being tested more than other members of the population, and there are a lot of healthcare workers in the population generally. We also know that. For that 25%, only about a quarter of them, and it's still a significant number that we want to reduce, have picked up that infection, we think, in the course of work. About 50% of them, it's community transmission that explains it. In other words, there isn't an identified link that's associated with their healthcare environment. We think it's picked up outside, and about a quarter of them, again, associated with travel. And so, no more than anybody else, healthcare workers pick this infection up when they travelled abroad, and although travel is reduced now as a phenomenon, and they pick it up in the course of ordinary social interactions, either with each other or with society generally. And so the number of about 6%, we think, is the number that have picked up this infection in the course of their work.
Just if I could add to that, sorry, is that the advice we give, of course, to people who are symptomatic is to self-isolate regardless of the timing of testing, and that is even more apt for healthcare workers given where they work and given evidence abroad that some healthcare workers in study abroad continue to work while they had early symptoms before they knew they were positive. So one doesn't have to imagine how much harm that potentially could do in terms of transmitting the virus.
Can I ask how many people are currently waiting for a test?
We have very few people. I haven't got the exact figure, but at the moment I can tell you that the capacity of our testing centres, that's to say the swabbing centres, is able to easily meet the demand coming through since the case definition was changed and a lower number of people now conform to that case definition.
And this lab in Germany, how many swabs are you expecting to send there?
I can't tell you the exact amount. We're trying to improve the flow so we can expedite the contact tracing, even though we brought in as I said, the policy earlier of going direct to contact tracing. We expect those numbers to start coming back in the coming days, the results to come back in the coming days and week.
It's not very timely. Just the state exams, I think a lot of students are very concerned, are they going to go ahead, are they not? You know, can you imagine a situation where the restrictions would be lifted by so much that, you know, hundreds of students wanting into exam?
So look, we keep that under continuous review, and in our engagements on a cross-government basis, we have had and will continue to have, in as much as they need them, engagements with our colleagues in the Department of Education who are challenged with trying to respond to the environment like every other sector. It's impossible to make that prediction at this stage. I'm a parent of a Leaving Cert from last year and a Leaving Cert next year, and I understand absolutely the situation that people are in with children, and I understand the perspective of students and why they'll want to know the answers to those kinds of questions. We'll continue to work with the Department of Education to try to help them in making whatever assessment they can make and whatever contingency plans they need to make in relation to these, with full understanding, if you like, of the impact of this.
That was the last question, so this is just going to be a clarification. Dr. Henry, you were talking earlier on the start, and just there with Paul Cullen again about the surgical mask and respiratory masks. And I'm just obviously not much of a presuming respiratory masks are at a higher level than surgical masks. So I'm wondering, did you order respiratory masks and receive surgical masks?
No, thank you for the question. What I was explaining was that some of the items that came through on the consignment, on the early consignment, was classified and delivery as a respiratory mask, but could be more usefully classified as a surgical mask, which is a different type of protection in a different situation. But the respiratory masks, we've ramped up production from internal sources. IREMA in Limerick are now doubling or I think trebling their production, and we're hoping to address the ongoing demand, particularly for masks, through that and through alternative sources we've identified through procurement, which are coming in as I speak.
Thank you, everybody.